Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy and honored that you chose to spend this time with us, and we anticipate a very lively discussion about an issue that is of grave concern to our community. Without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Neighbor Stephen. And how you doing, Dr. Walks? And Dr. Hines is on. We do have a distinguished but frequent guest on our show. He basically pulled my bacon out by agreeing to be with us today, and that is the famous Dr. William Lawson. I met Dr. William Lawson some years ago, and he has an entirely long curriculum vitae. He is a psychiatrist by training. He is a professor now of psychiatry at the Washington University School of George Washington School of Medicine in Washington, D.C. He's been the head of psychiatry at Howard University, some universities in Texas. He's like a psychiatrist, and he has agreed to speak with us about substance abuse disorder or the use of opioids. And these are medications that take care of pain, and they cause a lot of potential side effects, both mental as well as physical. But before I do that, I've been thinking a lot of the past couple of days, and it won't be a matter of discussion at this point, but I've seen wall-to-wall coverage on the networks, particularly the cable networks, about the war in Israel, and very little mention of the other side of that war, except that we support wiping them out. And maybe one day within our 501c3, we can discuss the real historical significance of our choice of sides in that. And by our, I mean the United States of America, and how this fits in with who the people of Israel really are. What is the meaning of Zionism? What is the ethnic derivation? What is the political derivation? And what was the motivation of the League of Nations in the late 1900s to give a dispensation for that country to be formed? But that could be an interesting discussion that we may have in the near future. But I wanted to go to our honored guest, Dr. William Lawson, and speak about opioid use disorder. Dr. William Lawson.
Thank you very much, Dr. Maxey. Just want to note that I just came out with a bout of COVID myself, and I'm also right into allergy season. And for those of you who have allergies, I had the experience, didn't even know I had it till I took a test. So for me, literally no transition from one to the other. I also want to compliment Dr. Maxey for bringing up the importance of looking at the historical cultural aspects of these wars in terms of where these people came from. And I agree, that would be a very interesting and important talk. Always making sure that the other side is dangerous and somehow a threat to our survival. I will now share our screen, and whoops, let's see if I can find the right one. And it is now shared. And I just want to note that this was actually prepared very quickly. Very quick because I got notice for 2 days ago, but luckily I was giving another talk, so this would fit in. So just very quickly, first of all, is everyone's shared screen and is audio okay?
We can
Audio
see your
fine.
screen and the audio's fine.
Great. Going right into it. This is straightforward to this audience. There's something called the coronavirus, COVID-19. It was novel, no built-in immunity, no reliable vaccine, and no confirmed treatment initially. So that created a great deal of stir. But the other thing was that it uncovered some unresolved issues in mental health, substance abuse, and in chronic disease. And I just want to emphasize these, that simultaneously with the COVID epidemic and right afterwards, rates of suicide took off among people of color, and deaths related to drug overdose also increased. Now, we can say that this was an interesting and strange coincidence. But I want to suggest two things. One is that it was not a coincidence. There is some sort of causal relationship, not necessarily the COVID causing these, but it's associated with some common variables. But also, a lot of these other epidemics has started pre-COVID, and that in some ways, COVID uncovered some of these issues that we are somehow sleeping through. What has happened with COVID, but also with these other factors, the life expectancy has dropped. It's been related to a surge of drug overdose, but also of suicides, and in our community, an increased homicide rate. And I just want to emphasize these in terms of the impact on life expectancy, because these are behavioral variables. That is, you will not cure them finding a vaccine. You will not cure them finding a new medication, not necessarily a new medication. You will not cure them in terms of some technological events. These are human behavior that emphasize the importance of the issue of mental health in terms of what's going on. So, and part of this, of course, relates to some psychosocial variables, the reality of history. One of them is racism and its consequences. We talk about racism, we talk about people's attitudes, but I think the real action is done by looking at what we call structural racism, which is incidentally is almost banned from being discussed in some states. And the idea that racism is not simply individuals' attitudes, but it's also built into the nature of our society, into many of our core institutions, and has led to disparities in access to care, and also related to these other epidemic-like activities. It's not that is that suicide rates, depression rates, rates of some chronic diseases and others have increased in recent years. Some of this, I think we're well aware of. We have COVID was related to a high mortality rate in vulnerable populations, spread easily. It emphasized social distancing and vaccinations. And again, keeping that log aside, exposing other kinds of issues, the vulnerability of the social structure in terms of many of our African-American communities, and the trust and mistrust of the physician community, especially in relation to vaccinations. So those other epidemics, the drug overdose rates, the suicide rates, are, I think, intimately tied in with these factors. And we also have to look at other implications, and that is, we're finding, and again, these are not new issues, problems of mental disorders and substance abuse, general poor health in African Americans in general, irrespective of income, and often more related to where people live, because of limited care. There's been a push to try to say that we have some sort of genetic predisposition to get sick. In fact, the opposite is probably true, which is why slaves are so valuable in a developing country. But there's also such disorders as hepatitis C, AIDS, cardiovascular disease, CNS insults from head trauma, as well as from inappropriate drug use, and of course, COVID. And again, all of these are interrelated with that common variable, and that is structural racism, which is interactive with the endemic burden that many of these folks have, that's led to and emphasized limited access to care, which is in turn related to redlining, this designating some areas of our communities and cities that are not to be developed, that will not have key resources, that even when the rules and the decision of redlining may have been reversed, we still have many communities that do not have hospitals, that do not have providers. And that's my own personal experience. I'd like to compare Washington, D.C., a relatively wealthy African American community, with Austin, Texas, one of the fastest growing, wealthiest communities in the country. But when you look at them in terms of their African American communities, we find that their African American communities are very similar, not having no healthcare providers. I just discovered the last African American male psychiatrist that was in Austin, Texas before I left. Absence of hospitals and absence of healthcare providers. There's also a problem of misdiagnosis, underdiagnosis. When we are sick, we do not know it, and others do not know it. And another phenomenon called weathering, and I'm going to come back to that. Just wanted to say that I tried to document some of this with my book, African American Health, that I encourage those of you who haven't seen it to reach out to it. It is my editorials that and it is available on Amazon. So some of the structural racism relates to societal events that persist. We're now finding more and more evidence that societal factors, such as early adverse events, occur early, bad things happen to kids when they're born, right afterwards, parents divorce, housing is poor, malnutrition, and so on. But that these events not only affect the developing child, but affect the later of life. And we're now finding that what happened when someone was a toddler, when someone was preteen, that they had disproportionate number of chronic disorders, such as diabetes, stroke, hypertension, as well as increased likelihood of mental disorders, persisting, complicated post-traumatic stress disorder, as seen in many of our veterans, persistent, complicated depressive disorders, all increased among our community. And I mentioned concept of weathering. This is from Geronimus, who noted early health deterioration among Black folks, but also noted that because of the early health deterioration and the accumulated effects of repeating experience with social or economic adversity, political marginalization, that there are physiological changes that occur in the body. And this leads to not only disadvantages in terms of risk for disease, but also a general disproportionate aging that we see in African Americans. And I frequently had the experience when I had talked to my patients, and I had one guy come to me and said, I like having treated you young folks, but haven't had the kind of experiences I had. And I'm not 70s, and this guy was in his 40s. But yet, objectively, according to our colleagues, he looked much older than I did. And I'm finding that it's a frequent and chronic occurrence. That, especially if we look at folks and they have been involved with ongoing substance abuse and others, they look ancient. And that's because physiologically, they are ancient. So also, not only do we find weathering as well as early adverse events have a wide range of effects in terms of psychologically, they also have wide range of effects in terms of behavior. Disparities in terms of insulin resistance, African Americans more likely to have insulin resistance, especially if they had early adverse events, and especially if they're exposed to chronic structural racism. We have differences in terms of sleep. All too often, in the inner city, young kids just don't get adequate sleep. It's not because of the noise in the community, it's because of the psychological noise that they're exposed to on a day-to-day basis. We also have an increased risk of producing on abdominal fat, same process. Increased risk of metabolic syndrome, reduced heart rate variability, which is another marker that we've associated with stress, and also the actual size of the hippocampus, which we did a study showing that there's hippocampal shrinkage if you have post-traumatic stress disorder, and we find that in African Americans. We noted that there's a mental health impact, not just about these factors, but also post-COVID. We found that many folks in our community are exposed to stress because they're not only surrounded by death, but also there's increased financial burden. Despite the government's efforts to try to reverse that, there was a financial impact that has lasting effects on our African American community in terms of housing costs, paying household bills, and these are all tie in to mental health. And also, when we talk to folks, when we interview them, we find everyone agrees that the pandemic negatively impacted mental health. The point I'm making is that it's not an acute event, isn't going to be an ongoing event that will have negative impact on not only them, but also much more likely among African American and Hispanic patients. And also confluent with that, ongoing in terms of recovering from the pandemic, we have heightened anti-Black, anti-Asian racism, and also violence. And so we have not only increased suicide rate, increased police effects on our community. And then we have the problem of missing depression, missing bipolar disorder, missing post-traumatic stress disorder. We document this in an earlier book, but these problems continue to persist, and the misdiagnosis, not only in general medical conditions, but also in mental disorders associated with delayed or refused treatment, with people looking at new treatments and research, and especially, and I get the comment, that's white people's medicine, that even though the vaccine for COVID was helped developed by some Black folks, people are more apt to seek not only self-treatment from drugs of abuse, but also from people with questionable medical credentials, such as in my hometown, going out looking out for the who's you woman. So we're seeing increased stress and anxiety, depression, and disturbed sleeping, cognitive impairment, all tying in to use of drugs of abuse as a coping mechanism for dealing with stress or boredom. Just want to note that, so you know, opiates and opioids, the important point is one's natural, one is not. But with the technology that allows us to develop opioids, we now make them more available, have painkillers for everybody on the planet pretty much. And people are using these not only to feel better, because they perceive these agents as, and I hear this on talk radio all the time, as reducing anxiety, worries, fears, or depression. They really don't. And they have no effect on most major psychiatric disorders, but have a transient effect because they make people feel good. You have novel feelings, novel sensations. As I told one patient, you carrying your recreational issues right in your medication. So these are multiple effects in all components of the community. There's medically, as I mentioned, economic impact, and the social impact. Another point that we increasingly appreciate is that early substance abuse increased likelihood of disturbing psychiatric disorders later in life. We trace it to the 20s, but we're now extending it. Dr. Chapman and I was going up into the 50s and 60s. Early substance has the impact on the person stops using it. So we're well aware that these available for pain and euphoria. We have the oxycodone issue, where the technology of these agents were made available to our community, and we have different faces. That as we separate the prescription drugs from the drugs folks get over the counter, but there is no difference, especially in terms of the impact. We've seen the data showing that overdose deaths have increased, continue to increase, not just with people who are on drugs, illicit drugs, but also on those who are on prescribed drugs, not only for the naturally occurring drugs, but also for these agents that are synthetic. It also has an impact in terms of the synthetics have now become the predominant issue in terms of overdose drugs. And it's important because politicians are now trying to make the point that agents such as fentanyl are coming across the border, when in fact, the technology and the availability of ingredients are right in our own country. And much of this fentanyl is now coming from folks developing useful agents at this time in our communities. These agents are not effective very well for chronic pain. Do they help acute pain? But oxycodone and others came out saying these drugs are less addictive, and they're not. And the company got fined. Excuse me. But what drove the company, although they were reluctant to admit it, is that they're marketing on the idea that drug abuse was primarily a Black thing, whereas if you prescribe drugs like oxycodone, it would be associated with suburban and white communities. And initially, the overdose rate was higher in the white communities. So race does play a role in terms of the decision, and it continues to play a role because of how we perceive, how do we treat drug abuse. And that is that African Americans disproportionately, or maybe 14% of regular drug users, about the same percentage of the population, but over this percentage, 37% more in terms of nonviolent drug offenses. So the intervention that's been made to our community is that is confinement, increased record breakers, grabbing people off the street, even though that folks are arrested and put into incarcerated, they're not get more treatment. They're actually less than 15% will actually get treatment. Good news, treatment works. But we continue to face disparities in terms of getting treatment. Jails and prisons often do not provide the treatment that's necessary. And in addition, less likely to get treatment than the white incarcerated individuals. So the chances of treatment are slim and none. Nevertheless, treatment and rehabilitation unfortunately remain underfunded, whereas their monies are going to punitive actions in the correctional system. We have treatments, we got cognitive behavioral therapy, we got contingency management, we use positive reinforcement. A lot of counselors are now become familiar learning their own motivational enhancement therapy that may have been retrained to use widely. We have family therapy, especially for you. You president of the American Psychiatric Association, who's a big proponent of motivational interviewing, which does not require extensive training to provide, but yet more folks just don't get it. We also have 12-step programs, harm reduction programs, which has been reluctantly applied in the U.S. Recovery, I just talked to the recovery community of peer recovery supporters, which is important now because of the lack of fully trained providers, and we've got to have individualized treatment programs. We now have medication-assisted treatment, detox services, which I don't think is treatment, and residential rehab programs. And we have now methadone, variants of buprenorphine, long-term, short-term, naltrexone, medications that clearly work with opioid addiction and alcohol, and to some extent nicotine. Unfortunately, it's not been studied in people with comorbidities, which are much more likely in African Americans. We tend to have mental and complicated mental disorders as well as with substance abuse disorder. Also, less likely behavioral treatments work very well in combination, but many of our programs simply do not offer them to the extent, even though they work very well. And then Dr. Chapman has emphasized the point that we've now have worked out various kinds of genetic studies. We can now identify most genes, and that's led to advances in pharmacogenetics. And one of the observations is that African Americans, certain alleles we find in African Americans are not functional. And so what we find is that many of our medications, including, by the way, buprenorphine, not metabolized, tend to be metabolized more quickly, and that can lead to ineffectiveness in the usual recognized doses. The FDA is beginning to recognize that and has made more flexibility in terms of buprenorphine availability, although it's still an ongoing propagation. And we got to go beyond the chemistry. Can't just give them medication and forget about it, which some programs do. We got to provide these other services: behavioral therapists, peer support, cultural awareness, to get people to be able to participate in these kinds of treatments. Unfortunately, what we do find is that while in recovery and psychiatry, there's no acceptance of long-term disease, powerlessness, humility, ambition, autonomy. These are all very important in terms of addiction recovery, and could be in terms of mental health recovery. It's a provider. Now, another factor that's also important is we look at, and this is that there's a comorbidity in these disorders. Again, mood and anxiety disorders are much more common among non-African Americans, because, and it's much more difficult to treat because we have dual treatment systems. Substance abuse is treated in a different system often, in different location, different funding, different philosophical events than mental health. You need to have comorbidity, but it doesn't happen, and the result is poor outcomes. So we need one system, one locale, comorbid trained staff. We need to have folks recognize that you can't just treat mental health and then put them in substance abuse or treat substance and put mental health. It doesn't work. And separate facilities does not work. The other elements, of course, are culture, psychoeducation, vocational rehab. Folks get out come out of jail, come out of substance abuse program, and don't have a job. You can't get a job. So you need to look at vocational rehab and also various kinds of support efforts, which usually are underrepresented of African Americans. Then another key element is that Black folks get treatment from Black folks. Hispanics get treatment from Hispanic providers. But there is a problem. That is, while we're now finding great evidence that African American patients do much better with African American providers, and it's been well documented for OBGYN and some other general medical conditions. I just studied with Chiefs about 20 years ago in the VA system, showing that African Americans did much better if they had a mental health and substance abuse if they had an African American provider. And the interesting thing was that we found that the white patients did better for the African American providers. And some of us think that's because of a selection process. That is, that Black folks who providers had to be good to get appropriately credentialed. So it's, unfortunately, our system is designed for beyond the white English speaking and I think middle class populations. And as a result, are much less likely to get treatment in the ideal way, despite the fact that there's strong institutional resistance to the concept. There's, so who's that down there? That's our diversity trainer. You can't let him go and do his thing. And then what I'll call the right now this concept of leprosy. Certain disorders have social economic consequences far beyond the physiological effects. So leprosy has led to community isolation and spread far beyond is needed for the disease. So it also occurs in any disorder that's linked to a Black disease, as we've seen with AIDS, as we've seen with COVID. So we gotta get out and educate our communities about substance abuse as a treatment of illness. We gotta look at some of our resources, and these are just some of them. We have a number of nonprofits that are involved. As we're not forgot to need to put up the National Medical Association. We're now working with some new treatments that hopefully will make a difference. This is the real work with another treatment for long-term drug abstinence that's different from some of the others. And this is that we know that the drug abuse is characterized by craving, compulsive drug use, tolerance, and withdrawal symptoms. Well, my colleague Dr. Woulier has developed a technology that can change that, because we recognize that many of the treatments we have are blocked by the complex brain disorder, and affects people irrespective of background. We've seen an increase in lifelong prevalence of these disorders, and also has profound physical consequences as well. But what we find is that a lot of relapses probably result from abnormal reward drive, an inability to make mental simulations that non-drug activities can lead to pleasant outcomes. So we're focusing on the orbital frontal cortex plays an important role in abstinence by providing a cognitive map linking non-drug activities to pleasant outcomes. So what we're suggesting is that drug relapses are controlled by negative stress relations, emotions controlled by the OFC, and that opiate and cocaine use impair normal OFC and concurrent use of these drugs. This is just showing the impact of it. And we're suggesting that order identification may alter the function of the orbital frontal cortex to improve decision making and also mood regulation and reduce the likelihood of relapse. So we have a process in which we provide natural substances to provide neural stimulation in this part of the brain, involve a system to nebulize these extracts, and we've demonstrated that using this, we've actually worked with people with partial cognitive impairment, with chronic pain, and the results have been actually very positive thus far. In these preliminary results, it's shown that we've prevented relapse in 95% of the patients. We're now at the process of looking at larger populations to see how well this can be generalized. But the important thing is using these stimulus seem to make an impact in terms of outcomes for folks. So closing thoughts, Nelson Mandela always said, this always seems impossible until it's done. Thank you.
Dr. Lawson, I certainly appreciate the thoroughness, the largeness, and everything that you talked about, and I appreciate you doing this on such short notice. And one thing that I'm stimulated to say that I believe we have to go back to our once a month Wednesday night where we can have our medical people listen to you in depth, because this is the most comprehensive talk I've seen in years and years on drug abuse. One of my comments, and I remember a number of years ago, maybe 20 something years ago, I broke my tibial plateau in about 32 places. And I was at a ski resort to give a lecture to the medical staff. And I was given a narcotic. I gave the best lecture I ever gave in my life after that narcotic. And for the first time, I recognized why people like to take narcotics, but I was smart enough not to continue it. So one, I'd like your comments on, there's a complex system as a primary care doctor, internist, pharmacologist. I see patients all the time that are not given enough pain medication. And I see patients who are given pain medication enough, but it continued to cause an iatrogenic or doctor-caused addiction. So I'm caught between people who abuse just for the good feeling and people who abuse because they're addicted. It could be a 65-year-old multimillionaire who had an injury. How do we separate and treat appropriately those groups of people?
And I'm not sure if you can really separate it. We used to talk about the addictive personality, yada yada. There was some people who had a predisposition to addictions. But when you look at, for instance, folks that are genetic basis for addiction, for instance, offspring of alcoholics and so forth. But you find an interesting phenomenon. Some folks recognize early they got a problem, become abstinent, never drink again. Whereas others, of course, have a lifetime of drinking. The issue is to make sure that you're not just getting folks away from certain substances, but when you provide the support system. Almost all of our drugs of abuse have been developed in other societies, which are using the religious ceremonies, which people use these drugs and just don't have any problems because it is part of a larger cultural overlay. Unfortunately, our folks are faced with chronic stress, as I said, systematic racism, all kinds of factors that these drugs can provide some sort of relief. But what we find is that folks, for instance, physicians and researchers, we do become addicted, do much better in terms of various kinds of treatment programs. And also many of the initial drugs of abuse, when their first trials were done by scientists who tested it on themselves and said, stuff doesn't cause addiction. Again, because of the lifestyle and the support system that we had. So it's not simply a matter of making sure that we get folks deep, and that's why I don't call it detox treatment. Folks into detox them, but also to make sure that they're led into a support system. And I think this is something that's necessary, even if the person doesn't show signs of detoxing early, to make sure that it's done in the context of explain to them how these agents work, that and especially the point that these are not effective treatments for any kind of personal problems or long-term emotional issues. It just does not pay your bills, and it will not make your boyfriend like you better, and so forth.
My follow-up comment, not necessarily a question, but in my conspiracy theory self, I know that the way the British Empire subjugated the Chinese Empire was to make them take opioids by putting a gunboat force outside of China and saying if they didn't take the opioids, they were going to physically destroy them. So I know it can be used politically to subjugate people. But let's go to our co-moderators, Dr. Neighbor Stevens and Dr. Walks, and see if there's anything in the chat we need to talk about. Again, thank you for this comprehensive addressment.
Well, yes, I'd like to echo the appreciation of the very inclusive conversation, which highlights a lot of the issues. And time won't allow us to go very deep into some of those issues, but there are just so many, but I would like to focus on when there are people, when there is a patient who recognizes that they need help and can't access help, which happens all the time, whether we're talking about, and I don't understand, I've never understood the separation between substance abuse and mental health. It just never made any sense to me. But access to those resources are inadequate for the need. What do you see happening, if anything, to help alleviate this really acute shortage of appropriate mental health and I'll follow the rules, substance abuse providers?
Yeah, you raised that. I think I'm sure Dr. Walks will weigh in on, because he's worked in similar systems as well. The problem of how do you, given our present system, resolve this? Part of it's been legislative. There's been legislation to promote single systems, but unfortunately, we run into the concept in our country, especially, which is also led to a resistance to harm reduction approaches. That there's two worlds. There's one world where you got these poor, helpless, mentally ill people who can potentially become murderers, and then there's this other world where you got these other people who are very naughty, who are evil, who are shameful, and that blocks a lot of different interventions. So it's setting up, I've found churches much more willing to provide support systems for people with depression. But when I start saying, well, let's see if we can get these a drug detox center of support AA, support Narcotics Anonymous, tremendous resistance in terms of the concept. The idea of using public monies to support programs to reduce substance abuse, with all kinds of resistance, and in terms of even for setting up support organizations. And that's why I mentioned the leprosy point. In many ways, yeah, I know I'm still trying to start the new term. That substance abuse is our new lepers in many ways, even though it strikes irrespective of social class or income. Whereas in some ways, the good news is that we're now recognizing mental illness as perhaps an okay disorder. Now, then the question of getting providers. Clearly, there's inadequate number of providers, not helped by the fact that because of these divisions within the system, the compensation for the kind of care these individuals have further complicate matters. And I initially was resistant to the idea of having, I wanted to make sure that everybody should be a psychiatrist, a psychologist for you treat folks. Now I've become more flexible, and I think the use of virtual practice is one way around it. And I can treat far more patients now when I have a virtual system than when I was treating everybody face to face. But also the availability of medication assisted therapy. We have, which has made a huge difference in terms of being able to provide at least some basis of support for individuals, and which some of them I most never use again, but some of them will do lay enough so they can get some additional treatment. And the use of peer support systems, call them lived experience folks. It's a two-edged sword, but if you have the number of adequately trained peer support, you can really make a difference. On the other hand, in the past, I've dealt with folks who anti-medical, anti-health, and then that can actually worsen the situation. So I'm much more leaning to the idea, do more to improve the quality of services that can be provided through our technology and peer support. That I think we can outreach to more people. But we got to deal with the barriers that we create ourselves. Legislation that's directly these systems, inadequate resources, trying to spread the word that somehow medications or even contacting physicians is somehow evil.
Thank you again. Dr. Walks?
One of the highlights of my professional life is my connection with Dr. Lawson. It's always, there's an old saying from the old people. It says, show me your friends and I'll tell you who you are. So I'm
wait just a minute. Did he invite you to his barbecue, Dr. Walks?
Dr. Lawson invites me every year, Dr. Maxey, and I don't know why you're not there. It may say something, but we'll get to that next week. Again, Dr. Lawson, excellent. There's a question in the chat from Dr. Gibson about how could the motivational interviewing techniques that you mentioned, Dr. Lawson, could leveraging those lead to greater success in addressing the opioid epidemic?
And of course, what I found is that can be very effective because it does not require in-depth psychotherapy. Simply requires you being able to have a conversation with the person and allow them to be able to assess the risks and benefits of drug use. Doesn't work for everybody. Folks with severe mental illness, individuals who are just out to hustle. But for a lot of people who really want to get off these drugs, it can make a world of a difference. So give them one more tool. The initial tool can be just tell them bad things will happen to you if you use a long time. But then you can say, well, let's look at you using what will happen and what may not happen. And if that is inadequate, then we can always add some medications to therapy on top of that. Using this, we don't need to have a person, as we said in the old days, lock them up in some isolated facility to keep them from use, but to be able to treat them and allow them to go about their own business and develop their lives.
So one of there's several, of course, points that I resonate with or wanted to expand on from your presentation, Dr. Lawson, which is it's always a challenge because we don't have time to do all the things that we need to do or cover them all. But a couple in particular. One is you mentioned about this fact that folks will do better with people that are of some shared experience. So if you have Black patients with Black providers, if you have folks that have that lived experience at the peer level of connection, that can be an enhancement to a positive outcome or can lead to a more positive outcome. And then the other thing is so often we don't look comprehensively at the treatment of the person. Somebody comes in, they have an opioid addiction problem. We say, okay, let's get you detoxed and let's get you some medication assisted treatment and away you go. And so many other, it's like every other kind of medicine, right? It's like you anything that we want to help you get better from, we typically just don't give you a pill and send you away. We will typically connect you with some sort of behavior modification, some sort of additional therapy, and all of the things that people need for an individualized, comprehensive treatment plan, which is what we think everybody should have. I think one of the challenges with opioid addiction in particular is something you mentioned, Dr. Lawson, which has to do with some of the reasons that folks may use or overuse and then become addicted to these kinds of medications. Life is tough out there. It's hard to sometimes face all the things that are going on in our lives. And I think we have to recognize that not everyone has the same level of resilience. Not everyone has the same level of resource. And so we may just get overwhelmed and run over by the circumstances we face. And not a good escape, obviously not a long-term escape, but those drugs can, as Dr. Maxey, is there any videotape of that presentation you did while you were using your opioids?
I think that was before the advent of videos. But I think you hit on a major point, though. I want to bring out again, and Dr. Lawson, you spoke about a number of issues that can be side effects of opioid use that were physiological, the advanced or increased aging, and a number of things. But other than addiction itself, could you focus a moment on some of the other things that we should be careful of if we're taking opioids that can harm us in some way? And I know it's very enticing to feel good, but there's some other reasons that we don't want people to overuse these drugs and medications.
Yeah, that's an excellent point, excellent question. And I think I'm especially cautious in individuals who have major psychiatric problems. They clearly interact and they clearly comorbid. So I'm diligent about making sure that anyone getting ready to start, if they really do have major depressive disorder, we say, well, maybe they're depressed because they have drug use. But it may be that the drug use was secondary to the depression. And if that's, and also the unrealistic expectation that the use of these drugs will somehow make the depression go away. So I tell them up front, some of these, we have agents that can deal with depression and that are very effective, and that depression literally can be resolved for years. But what we found is that you use cocaine or you use heroin, you feel good for a brief period of time. As soon as you stop the drug, it's back. I'll go even further than that. It's worse. And it's well documented that some of the other benign agents, like the benzodiazepines, while they have can have antidepressant effects, tend to worsen depression rather than to help it. So one of the things is to make sure that we have some sort of screen or some recognition. And I might also add, and some of these folks have bipolar disorder, and I'm just running so many patients. I've taken the Valium or Klonopin, which has been shown to reduce mania. Took all these other drugs, but I still got this, and it's worse than ever. And then the other thing is unrealistic expectations about what these drugs will do in terms of your personal problems. And it may seem like it's obvious, but you sometimes have to explain to folks. You have a difficult relationship, poor relationship with someone, even though you feel glorious when you're drinking, when you're on cocaine, when you're relating to this person, the relationship itself may be heading towards the toilet. So you need to let them in advance know that these agents do not improve relationship. I'm not as shy when I'm on them, or I can go out. Yeah, but the question is not how you feel, but what is the impact on the other person? And encourage the person to be empathetic. See, how is the other person liking you? Found alcohol, alcoholic families. Some folks are enablers because dad is a much more jovial person when he's drunk. But when in fact, If you look at what's happening to the family as a whole, it's also very destructive. So also we look for, and it's secondary gain that may be gotten in terms of use of these agents as well. And I emphasize opiates and cocaine, but also these issues come in terms of all of these potential drugs of abuse, especially the benzodiazepines and alcohol.
Can you comment on benzodiazepines like Valium and Librium with
Yeah, it is a
and
wonderful
respiratory
drug for
depression?
the development. Yeah, but you gotta recognize their limitations. Many mental health clinics, they actually discourage their use. And the reason is they are safe, used in isolation, used in a reasonable dose, but used with other sedative-like agents like opioids, you can die unexpectedly at relatively low doses. It is back a relative contraindication. Also, these agents, generally, most of them do not have long-term antipsychotic or antidepressive properties. Short-term, it may be, the person will feel good, but long-term, you become tolerant to these agents, and those kinds of symptoms will break through, and the person ends up in a worse situation as they try to increase the dose to try to make these symptoms go away.
Can you explain tolerance just a moment, Doc?
Yeah, repeat that?
Can you explain tolerance in just a moment?
Sure,
You
tolerance
talked about
means that
tolerance.
you can take the same dose and it won't have the same effect. I've been on this 5 milligrams of 2 milligrams of clonazepam for years, and I'm feeling fine. But then I'm getting anxious again, having panic attacks again. Why is that? Is the medication broken? No. What we find is that the benzodiazepine receptor requires more medication across time. That the receptor begins to lose its sensitivity. And so you need to require more medication to get the same effect. This is a well-known phenomenon. Benzodiazepines, alcohol, a number of different agents will show this phenomenon. And it's important to explain this to folks because they say if you have, because there's some medications you never have to change the dose of. But these agents, if you want to get the same effect, you're going to have to go up at a higher dose or switch medications. And it's important when you try to get people off of them too. Because you'll find that even if you get them detox or get the dose down in almost unbelievably small amounts, they now require, they find that you just can't get rid of them.
Doctor, all I can do is call you very prolific and erudite in your expressions today. And I'd like to have you make final comments, unless there's some questions, Dr. Walkson, Dr. Neighbor-Stevens, in the chat, any hands raised.
There is a question in the chat from Dr. Sherrod requesting you say a little bit more, Dr. Lawson, about the causes of the malfunction in the orbitofrontal cortex.
Yeah, I don't want to see an idea that somehow that the organ is not working. And simply saying that you have to look at what does it do. Nature did not develop it such that it would teach people to avoid non-pleasurable things. It's doing what it needs to do, and that is help to serving as an orchestra, as trying to orchestrate the different sources of pleasure. There's just some research that last week showing that there's a common pathway for the pleasure we get from eating, the pleasure we get from drinking, the pleasure we get from drugs of abuse, pleasure we get from sex. But not only that, not only is there the sensation, but there's also the memory. And that is that the memory becomes very fluent in terms of how one connects with the other. So what we're doing is exploring the fact that in the past, the pleasure that's been exposed has been heavily linked strictly to use of the drug. We want to be able to re-educate, if you want, the system so that it recognizes that you can also give pleasure from other activities, such as talking to people, going to a play, participating in athletics, and so forth. The drugs of abuse essentially take over that component of the pleasure system, so that you're not interested in those things that you were before, that you have. And so what we're doing is try to reawaken those memories, when folks that folks derive pleasure from before they started using these drugs of abuse. And again, another risk factor for drug abuse is to look at for examination of a person's life. Simple questions like, what do you do before you were using? What was the hobby that you were doing before you were using? How did you spend your free time before you were using? Did you believe that there was hope in the world before you were using? Did you go to church before you were using? Did you have any relationships? And what you quickly find that for many folks is that there's often some, I would call it, I won't say it's a deficit, but there's this absence of some of those important pleasurable activities that people who didn't get on drugs use, or who people didn't who started using, just let them drop by the wayside.
Again, thank you so much. Are there any hands raised, Dr. Stevens, Dr. Walks?
No, Dr. Maxey.
Well, again, we thank you for your time and participation. I'd like to ask you for some final comments, Dr. Lawson, and then our co-moderators.
I just want to emphasize that we have an audience that is perfectly situated to address the concerns that we have. You mentioned what you don't see on the news. What you do not see on the news is the impact of our community being victimized, impacted by the structural racism, and the heroic efforts done by many folks in the community, nonprofit agencies, and others trying to address these concerns in a meaningful way.
Well, thank you so much. And we definitely want you back almost on a regular basis. There's so much that you put on the table that we need to break down more fully. And I'm just thinking of just brain function and behavior is a major topic that we can break down a lot in the future. So thank you again so much. Dr. Walks?
Thanks, Dr. Maxey. Again, thank you to Dr. Lawson. I want to just emphasize that one of the things that Dr. Lawson does very well that we can help with is a focus on new knowledge and better understanding. Dr. Lawson is one of those people that will do the patient care piece, but also the research piece. And we need to participate more in research opportunities so that the science that's developed and the strategies and techniques that are developed are relevant to the needs of our community, because they can be quite different. So with Dr. Lawson's focus on research and ongoing learning about how to take care of us, I wanted to just encourage folks, if your doctor asks you to participate in some kind of a research protocol, give it some serious thought and try to help us learn more about us.
Thank you so much. Dr. Napier-Stevens?
Thank you, Dr. Maxey. As we listen to Dr. Lawson, I hope that you heard the suggestion or the statement that a lot of the reasons individuals present with either substance abuse or mental health issues have origins from earlier in life. And so as we talk about this, I want us to simultaneously be thinking what to do with the current generations and people that are presenting. But my concern and many other pediatricians' concerns are that we have a whole new wave not coming, is actually presenting now, that is going to continue to move in a direction of needing help and help not being necessarily available. So I want us to think really holistically about substance abuse and mental health issues in our community, and remember that we need to talk about and do something about all generations.
Thank you so much, Dr. Barbara Neighbor-Stevens, Dr. Walks, and certainly Dr. Lawson for being available today. We'll be back next week. I want to encourage us to invite even more guests. And we're going to continue with our format of addressing current issues in health disparities that occur. Thank you so much for joining us. Thank you, Simon, and everybody have a great Sunday, the rest of the day. Thank you very much.
Thank you.
Good day, everyone.
Bye.